All right, welcome back everyone. So what we're going to look at now is we're going to take a closer look at pulmonary gas exchange, and then we're going to look at systemic gas exchange, right? So for both of these, I want you to think of the larger circuit that these are involved in, right? So for pulmonary gas exchange, this is involved in the pulmonary circuit. So think moving from the right ventricle to the lungs, exchange of gases, and then moving back to the left side of the heart, so the left atrium, right? So we're going to look at movement of oxygen. Which direction does it go? Into the lung, out of the lung. And then we'll look at carbon dioxide. Does it move into the lung or out of the lung? Remember, for both of these, whether we're talking about pulmonary gas exchange or we're talking about systemic, that we'll get to in a little bit, the gases are moving down their gradients, right? They're moving down the partial pressure gradients, okay, until they roughly equalize. Okay, so you can look at some of the changes here. You can see the various numbers and values of the partial pressure of oxygen and carbon dioxide in the blood, in the alveoli. What we're going to look at is an actual image here, right? So what we can see is that we've got a airspace, right? So here's our alveoli, right? And then here is our blood. Remember, these are the capillaries, these pulmonary capillaries. These are coming from the pulmonary artery, right? So remember, pulmonary artery from the pulmonary trunk. This is taking blood from the right ventricle to the lung itself. And notably, we'll talk about this in a little bit. What's influencing this movement of gases? One of the things, along with the pressure, is the thickness of this respiratory membrane, right? So this barrier that the gases have to cross, right? And remember, this barrier is extremely thin, right? It's something on the order of half a micrometer in thickness. Okay, so wildly thin. Okay, this is perfect for gas exchange, right? So you've got this simple squamous epithelium lining the alveoli, right? You've got this endothelium lining the capillary. Both of those are simple squamous epithelial tissues. So you've got this really thin layer of flat cells that is allowing the oxygen and the carbon dioxide to move across, right? So what you can see in this left image, right, the left side of this table, is the general direction of each gas movement, right? So oxygen is moving from the lung to the blood. Carbon dioxide is moving from the blood to the lung, right? So you can think about how did each of these gases get here, right? Well, the gas got here, the oxygen got into the lung via what we talked about in our previous set of lectures when we talked about ventilation, right? So we contracted our diaphragm, we increased the size of our lung, we decreased the pressure, and air moved from the atmosphere into the lung, right? And included in that air is oxygen, right? There's other things, but in this case, we're focusing on the oxygen, right? How did the CO2 get in the blood? Well, it was produced as a byproduct of cellular respiration, right? And we'll have whole separate lectures and discussions on cellular respiration in the future, right? But for now, no, it's a byproduct of our cell's metabolism, right? So it accumulates in the tissue, it goes into the blood, right? So it's moving from the blood to the lung, oxygen's moving from the lung to the blood, right? So this right image is showing the exact same thing, but the difference here is we're looking at changes in partial pressure, right? Or the difference in partial pressure, okay? So what this is saying is we have a change in partial pressure or a difference in partial pressure in the lung, in the airspace versus the blood. And we have the same thing in both, right? The difference is where is the partial pressure of the gas greater, right? Is it greater in the airspace or is it greater in the blood? Where it's greater, that's going to influence and drive the diffusion, right? That's going to drive the movement of the gas. So for oxygen, and remember, gases are moving from high partial pressure to low partial pressure, right? So this P, this is referring to the partial pressure of oxygen, partial pressure of carbon dioxide, right? So if we know that oxygen is moving from the lung, the alveoli, the airspace, into the blood, then we must know that the partial pressure of oxygen in the lung is greater than the partial pressure of oxygen in the blood. So we're moving from high partial pressure, 104 millimeters of mercury, to a lower, smaller partial pressure of oxygen in the blood of 40 millimeters of mercury, right? And it's going to diffuse down until they roughly equalize, right? The same thing is happening in the blood and lung for carbon dioxide, but in the opposite direction, right? So now we've got a higher partial pressure of carbon dioxide in the blood, a lower partial pressure of carbon dioxide in the airspace, right? So in the alveoli, 40 millimeters of mercury, and so it's going to diffuse again until they're roughly equal. Okay. So the specific numbers, I'm not as concerned with you knowing. But what I am certainly concerned with you knowing and understanding is where are those numbers greater? So in the blood, in the airspace, and how does that drive or how does that influence the movement of each of those gases? Okay. So what we'll see is, let me advance here. So what we'll see is that at varying points we'll have a certain amount of air coming into the lung, and we'll have blood going there to pick it up, or maybe the blood is dropping off air, right? So, or it's dropping off the carbon dioxide. And so there's a couple of things that make this process efficient, right? And so one of them is the thickness that we alluded to, right? So this very thin respiratory membrane, right, that we have here, this half a micron thick membrane. The other one is this extremely large surface area, right? So 70 square meters of surface area for the respiratory membrane across the lungs, right? And so what this is doing essentially is this is allowing for more area, more space for gas exchange, right? And so if you have any type of damage to the lungs in which you lose surface area, so in other words, you destroy your alveoli, or you change the thickness, so you increase the thickness, both of these are going to affect the movement of those gases and the amount of the movement, the amount of gases that move between the blood and the lung and the lung and the blood, right? So again, decreasing surface area or increasing thickness, both of those are going to negatively affect this gas exchange process, right? So there are changes, there's normal changes that occur to the membrane, or that occur to this process of gas exchange, and this is called ventilation-perfusion coupling. So what this means is that normally we will have a certain amount of air that is inhaled into the lung, and it goes down the bronchial tree, ultimately to the alveoli, and simultaneously we will have some amount of blood reaching the lungs via those pulmonary arteries and pulmonary capillaries, right? So normally we have a match, right? So meaning if you are ventilating a lung, you are perfusing that same lung, right? Or that area, right? So you're bringing air into a certain group of alveoli, and you're also sending blood to those alveoli, right? So this is called ventilation-perfusion matching or ventilation-perfusion coupling, right? You may also see these referred to as VQ, right? So a VQ coupling, or VQ, what we'll talk about in a second, called VQ mismatch. Okay. The Q stands for perfusion, right? P was already taken for pressure, so the next letter, PQ, is for perfusion. Okay, that's just how it is, right? So ventilation, this has to do with the air, right? So changes in bronchodilation and bronchoconstriction. So how much air is able to reach the alveoli, right? The perfusion, that's the blood, right? So referring to vasoconstriction and vasodilation, right, in the blood vessel, right? So normally this is it's paired, it's coupled together, right? So meaning if you are sending or if you are ventilating an area of a lung, at the same time you're ventilating it, you're sending blood to it, so you're perfusing it, right? So this is this idea of ventilation-perfusion coupling, right? So you've got a certain amount of air coming in, right? So arterioles dilate, right, in terms of the arteries, and so the bronchioles dilate, so the pulmonary arteries, or these arterioles dilate, arterioles constrict, the blood vessels constrict, right? Now, what you can have at times is something called a VQ mismatch, or mismatches in ventilation-perfusion coupling, right? So what this means is that you are ventilating a lung, Okay, so meaning your bronchioles are dilated, you're bringing in lots and lots of air into that alveolar sac and those alveoli, but you don't have the adequate amount of blood also being sent at the same time, right? Or conversely, you have blood being sent to an area of a lung, but the bronchiole is constricted, and so there's not a lot of air getting there, right? So for whatever reason, you either have sufficient air, so sufficient ventilation and poor perfusion, or you have sufficient perfusion and poor ventilation, right? So these are going to involve some type of maybe blockage or constriction in either the blood vessels or the airway, right? So maybe you have asthma, right? And so the bronchioles constrict, poor ventilation, but maybe you're still perfusing that area of the lung, right? Or for blood, maybe you have a blockage in the blood vessel such that the blood is not able to make it to that area of the lung, or not enough blood, but you're still ventilating, right? So in both of these cases, you have a mismatch in ventilation perfusion. So you have a VQ mismatch, right? Now, one thing that can cause a mismatch, or even really just cause a less efficient gas exchange process, is something called emphysema, right? So emphysema, this can occur due to smoking, almost always. This is damage to the alveoli, and it is permanent, right? So it's this irreversible loss of pulmonary gas exchange surface area, right? So remember, surface area, that was one of the factors that influences gas exchange, right? The other one had to do with the thickness of the membrane, right? So we've got the destruction of these alveoli, destruction of the elastic tissue, right? And if you look at, and I should have added a picture here, if you look up a picture of a lung, the histology of a lung that has emphysema, you'll see all of this excess space, right? All of this destruction of the alveoli resulting in this increased space, but you lose surface area, right? So remember, surface area, that's how we actually are moving the gases across, right? Remember that 70 square meters of surface area in the lungs? That is allowing the gases to move from the blood to the lung and from the lung to the blood, right? So moving in both direction. So you dilate and you decrease the number of total alveoli. This is resulting in poor gas exchange, right? You also have an inability to expire effectively, so meaning breathe out, expiration, right? Exhalation. And so sometimes you'll see patients with emphysema or other things like COPD, chronic obstructive pulmonary disease. They'll have these very short and shallow breaths, and oftentimes their chest will be much larger. So they'll have something called a barrel chest, right? And this is due to these short, and so imagine, and you can kind of test how this would be. So taking a big breath, right? Taking a big breath, and then exhale just slightly, and then inhale back in, and exhale just slightly, and inhale back in, right? So it's this very short exhalation, and you retain lots of air inside the thoracic cavity, inside the lungs, and so these individuals' chests, they end up being quite a bit larger, right? In individuals who have types of COPD, right? So let's stop here. This was kind of a discussion on pulmonary gas exchange. What we'll do in the next part is we will look at tissue gas exchange.